All right, well, good afternoon. Welcome to the Rural Health Association of Utah's 2020 annual conference, Building Partnerships for Rural Wellbeing. We would like to thank our sponsors for their generous support in helping to create this webinar series that has gone from a traditional conference. We would also like to take time to thank the providers who are out there on the front lines that are providing services to those affected during this time with the COVID-19. As you know, we are using the Zoom conferencing program. This is a conference common platform that is being used. We do invite attendees to use the chat section at the bottom to share with those in the community. And also we would like you to ask and use the Q&A section on the bottom when we get to that Q&A section. Now, lastly, one of the things that I would ask you that as you go through this, that you do keep in mind things that you might want to put into action after this in your communities throughout. Again, we will invite you to ask questions using the Q&A, just to let you know that this webinar is being recorded so that you have access to it in the future. Now, for those of you that are needing to earn a CEU credit through the American Academy of Family Practitioners, that information is located there on the bottom of the screen. So what we're going to do is we're going to begin. I am going to be introducing myself. My name is Mike Nelson. I am the Assistant Director at Dixie State University in our Multicultural and Inclusion Center. As we go through our attendees, I'll have them introduce themselves real quick. What we will do is I will give a little bit of context to what it means to understand equity and inclusion, especially in these rural areas. So as we look at Utah demographics, just to let you know is that right now when we have a portion of our demographics are those that are the youth and those seniors. Those that you'll see there is approximately 38% that are under the age of 18. A lot of those that are receiving services. Also, we have 49% of our population are females. And lastly, if we look down on the last two sections, race and Hispanic origin, as we see in the state of Utah, 90% of our population is white alone, with very small numbers of our populations for ethnic and racial minorities. And then we also want to include those special protected classes, our veterans who are serving, and also our foreign-born individuals. And this is going to be important as we start discussing what are those populations that are being underserved. And then these are the demographics, the racial categories that are by the U.S. Census. And again, we just had the U.S. Census begin on April 1st. And so hopefully everybody had a chance to participate in that and help to update that information. The three things that I want to include here, as you see on the very bottom, disability status. These are people with hearing difficulties, vision difficulties. And the two key things to remember is that there's hidden visual and visual disabilities. So visual disabilities are the ones that we see, someone in a wheelchair, someone using a cane, those type of things. But those hidden disabilities are those such as mental illness, dyslexia, colorblind, those different type of things, military status, and then also those members that are a member of our LGBT plus community. So just be aware that as we talk about culture, you know, in these rural areas, they are a completely different culture. And when we talk about culture, people typically think of racial culture. But we want to include that culture in essence is languages, beliefs, customs that are meaningful for social groups that make their social environments meaningful. And so what's important about that is that, you know, when you look at some of those rural areas, that is its own culture. It is different from going to Salt Lake. So just because it isn't race related, there is that social culture. And these are some aspects of that. You know, when we look at culture, things like, you know, Utah culture, there are certain beliefs, certain language, certain things that we have here. I'm located down here in St. George in southern Utah. We have Zion National Park just about an hour away from us, but we have the town of Hurricane. And as a southern Utah, when we hear people say the town of Hurricane, as it's spelled, we know that they aren't a part of our southern Utah culture. And so we recognize that. And sometimes, there may be some of those dispositions towards those outsiders. So culture is a lot more than just, where you live. It's also kind of the food you eat, the faith, the religion, the language. So just to be aware that when we talk about culture and as our presenters go into these aspects of challenges and barriers that they're facing, culture is a lot more than just ethnic and racial groups. So I do want to introduce our first panel speaker. Her name is Amber Rich. Amber?
Hi, I'm with Intermountain Healthcare and I'm a community partner specialist. In the last couple years, I've been working on a demonstration project called the Alliance for the Determinants of Health. And to what Mikey's point is, there's a lot of social factors that can create cultural barriers. And what we're looking at in particular in the Alliance is social need and these things outside of healthcare that really have the greatest impact on our health and this correlation between social determinants and improving health outcomes. And Amelia, who you'll hear from in a moment, has been a really great part of that in our community health worker team. If you'll advance, thank you. Oh, so these are actual zip codes that exist in Utah. And if you stand on one side of the street and you look to the east, or if you stand to one side and you look to the west, we might have a life expectancy discrepancy of up to 10 years. And it's really based on people's income, their educational attainment. And so those factors have a huge impact on our health and our well-being. And this project's really aimed at equity and creating more equity amongst the populations that are experiencing social need. So this is just kind of a well-known model that we see a lot in public health, but we know that healthcare only impacts about 10% of our overall health and well-being, and that the largest majority of our health is going to be derived from our social environmental factors and our individual behaviors. And I always like to compare this to like Maslow's hierarchy, and this is sort of our why of doing this, is we know that our healthcare costs are higher than any other country. We know that our life expectancy rates are going down for the first time. And if you'll go to the next slide, Mikey, we're putting 90% of our $3.6 trillion in healthcare in medical services, but that only impacts 10% of our overall health. And then there's this big mismatch in where we're spending our money in terms of where we could actually get outcomes. And sometimes people get nervous when we talk about social care because anything sometimes social in a really conservative state sounds, politically charged. But what we're really talking about are the fundamental foundational things that build our health. And those things are food and our housing and our utilities and our transportation. We'll go to the next slide. So this is some of the ethical dilemmas we're seeing in terms of health equity, is that we know that people that come from lower incomes, which often includes our rural populations, are going to have these drastic health disparities. Go to the next slide, thanks. So this is our alliance, and it really is a collaborative. Intermountain helped bring people to the table, but it's really been with our federally qualified health centers, our local mental health authorities, and it's really reaching across and including social services in the care that we're trying to give the people in our community. So these are identified social determinants that we're focusing on in this project, and the blue are the primary. And so this will be included in the slide deck, I assume, that will go out so you can review those. And then these are some of the amazing people that are assisting us with our work as these community health worker teams. And Amelia is a part of one of our teams here in Washington County. This is a project that we're doing currently in Washington and Weber counties. And these are the amazing people that come from the communities, that speak the languages, that go into the homes and help through peer coaching people to prioritize their needs and connect to services. And they've been a great ally in bridging that gap between mental health or behavioral health services, substance use services, medical services, social services, and they're like that connecting piece. So this is the model that we're working on. We screen for social determinants of health in a clinical setting. So that includes Intermountain clinics, it includes our federally qualified health centers, our emergency departments. We do identify those select health Medicaid members is our target population that are highest risk, meaning they've had a lot of ED visits. And then after we screen them, we ask them if they'd like to connect with a community health worker. These community health workers are not employees of Intermountain Healthcare, and Amelia's going to tell you more about that. So they're deployed throughout the community, and they really cross boundaries between healthcare systems and clinics and bridge that. The other piece that we've introduced is a digital platform, and this is it's a web-based software that we've contracted and we're giving free to all of our community-based organizations so we can send referrals back and forth to each other. And it eliminates that need for the Rolodex because we're trying to have all the services in one place where they can be updated and we can connect people and we have a closed loop about what happened after we sent that person. And really just trying to do care coordination across the continuum. So I thought this might be of interest. When we do these screenings, we use what's called a Prepare Light, and it's just sort of a triage screening that we do in a clinical setting that can be answered very quickly and having people identify needs. And then when the community health workers sit down with that individual in their home, they spend about an hour or so doing a fuller assessment. But these are the primary needs and social determinants that we're seeing identified through these two screening mechanisms. So we're seeing a lot of food, dental care, rent and mortgage, transportation, utilities. I don't think these are a surprise to anybody that's working with a population that is disenfranchised in any way, that I wish that I could wave a magic wand and create housing. That would be my dream come true. But the other thing we're seeing a lot of too is dental care. And one of the things that we found that the community health workers have been particularly effective is helping individuals recognize that they actually have benefits that will cover some of this. And sometimes that piece is just health education. So that's another big piece that we've learned through this, is just that it's not just identifying needs, it's helping people connect to these services that are available, identifying gaps in our community and what we can do to address those, but also just helping people understand sometimes these resources are available to them and they're just not aware of it. I love this quote, and this is why I feel so passionate about this work too, is because, you know, when we talk about different types of inequality, the type that affects our life and death to me seems of paramount importance. So it's just been a great thing to see how our communities have aligned and put away egos and really tried to come to the table to solve around some of these issues. And one of the things I think that's interesting is when we look at poverty or intergenerational poverty, it crosses over all those lines that, you know, we discussed. It crosses over race and culture and, you know, gender identity and all those things. They tend to all come under this umbrella of poverty or of social need. So I just, if you'll go to the next one, thanks, Mikey. That's just kind of my summary of some of the advantages and the things that we found. Amelia's here and she's going to speak to that community health worker piece more in depth. We've just seen some amazing success stories as we've been able to connect individuals to community health workers. And she's going to just share some of her experiences and the work that they do through her organization.
Thank you very much, Amber. So next up, we are going to have Amelia Brown working with the Community Health Worker Association of Utah. Amelia?
Thank you so much, Mike. My name is Emilia Brown. Thank you. And I'm working for Association for Utah Community Health as a community health worker. Every one of you, you're going to receive what is on the screen. And I just want to put like the summary for the code of ethics for us as a community health worker. A little bit of background why I'm working as a community health worker. I'm a Hispanic. I'm original from Mexico. When I arrived to the United States, I don't speak anything of the language, nothing at all. I was pregnant and I went to a community health center and someone interpreted for me everything about my my pregnancy. But the good thing is the same person who helped me, she invited me later when I was understanding the language. I was understanding how the Hispanic community, they don't know how to reach the services on that clinic. I'm talking that like at 23, 24 years ago. When I came here to St. George 10 years ago, I was helping Hispanics also. And I was saying like, you know what, this kind of plant, the best thing instead to use that plant is to go to the clinic. And I was inviting everyone to go and receive the services at family healthcare. And I was just inviting the people. And one day I decided, why not to go and serve as a volunteer at the clinic? Community health workers, we have different names. You will find us promotoras de salud, health advocates, and some other different names we have in the community. Why? When I receive the services, I just want to pay it forward to my community. And I notice the barriers of the language or to understand the culture is one of the biggest barriers. Sometimes the people, they're afraid to go to the clinic and ask for services. Why? Because they don't have the legal documentation. And I was first as a volunteer, and I was invited to participate as an AmeriCorps member and later as a community health worker. You can go to the next one, but this is just the summary you can review in your house. But in the article number 2, the promotion of equitable relationships, the respect for human rights is one of my favorite ones, and also the anti-discrimination. Every time someone say this person doesn't belong to this community because they don't speak the language, we're practicing something no nice. And I'm here like my team to serve my community. And we can go to the next one. Thank you. You can read about the interaction with other services providers in the article number 4, the professional rights and responsibilities. I want to talk a little bit more. Go to the next one, Mike. Thank you. They asked us to present like a case studies. When I was participating as a community health worker, not with the Alliance group, I was serving more the people who doesn't have legal documents. Or I remember this case was a lady, early 50s, no documents, no insurance, living in poverty, and the psychotic episodes and the mental health was so severe. And also on top of that one, diabetes type 2. When the community health worker, we visit the home of this lady, we identified several needs. And the good thing is with the right medication, the right dosage, we went through to navigate the system and obtain services for the family. She was receiving medication for mental health and also for diabetes. And you know, even if you have insurance, those medications are way too expensive. But when someone has the right medication, you have more help and you can participate in your community. And that was one of the amazing things. The next one is, because we're talking about equality and equity, sometimes we think, okay, equality is giving everyone the same thing, but equity is giving people what they need to reach their optimal health. I remember this case, this gentleman, he was living in a small studio, and because he was morbidly obese, he doesn't have the insurance, but he cannot do his daily activities. And it was really hard for him to move even from his couch to pass to his extra wide wheelchair. And he cannot use his own toilet. And he was using the bathtub instead. As you can imagine, this was something for the health point of view and sanitary things was really, really hard. But as a community health workers, we work and obtain the Medicaid services for him. Thanks to this one, he was transferred to a skilled facility someone else was treating and understand the situation to eat right, eat better, manage his weight, and obtain more help. And one of the things I was noticing, okay, when we go to the doctor, it's so easy to receive, okay, here, let's go to vital signs, and later, let's go to the scale. But what happened with this situation, with this different or unique situations? They don't have the weight scale for him. Or did they have any accommodations for the toilet? And those are one of my questions. And hopefully with the knowledge we have at this moment, we have more responsibilities to help more people. Amber, thank you so much for the opportunity to work. Right now, I'm working with clients and with patients who have insurance. But for us and for me as a Hispanic, I would love to still serving my community who doesn't have the legal documentation yet.
And hey, Mikey, can I just insert really quick?
Absolutely.
We would love for this resource to be available widely to everybody, but recognizing that this is a demonstration, we're trying to prove outcomes. We're trying to show other health systems that if you invest in social care, if you invest in a resource like a community health worker, there's a return on investment, that we can lower healthcare costs in the long run, that we can improve people's lives, that this is we're trying to show and gather data that this is a different and a new way to address social need, and that can be part of the responsibility of healthcare. So, so at some point we would love for this to have enough evidence and data behind it that it does move, people to include it in their health plans and in our government plans as we look at Medicaid and Medicare, and this kind of model can go forward. But for the time being, it is limited to Select Health Medicaid in Washington Weaver County.
Great, thank you, because that was one of the questions that was asked. Thank you, Amber. All right, and thank you, Amelia. The next up, we are going to be having Michelle, who works with the tribe, I believe in northern Utah. Michelle?
So my name is Michelle Chapuz. I'm a member of the Ute Indian tribe from the Uncompahgre Band. I've been working with my tribal community for over 20 plus years, and I've had an opportunity with my current position as a tribal opioid resource center coordinator to work with the other tribes in the state of Utah. So both Ghost Ute tribes, the Paiute tribe, and my tribe. I know we've wanted to work with our Navajo Nation and also our sister tribe with Ute Mountain Ute tribes. So my main focus is working on getting services in regards to opioid education and naloxone trainings into our tribal communities. With my experience, I've learned that when we're dealing with our tribal communities, a lot of the times we will hold trainings or services outside of the reservation communities. And so one of the challenges that a lot of our tribal community members have is the transportation to be able to get there. There's other levels of concern for tribal people to be able to go outside to other programs to get these services. And so I really work on focusing, the people that I work with, we work on focusing, bringing services into our tribal communities. So a lot of the work that I've done, I've realized that this whole equity and inclusion is so key to bringing these services within community boundaries. So like, for instance, I live in Fort Duchesne, and a lot of our communities, we have Fort Duchesne, but then like 14 miles south, or give or take, is our Randelette community. Then we have our community over in Mighton, which is outside of Roosevelt. So there's a big distance that our people have to travel. And our main services are actually provided in the Fort Duchesne area. So we have our Indian Health Service there. We have our diabetes prevention program there. A lot of our, our main offices are also there. And so I really like this, what Amber and Amelia are talking about. These are amazing, amazing ways to gauge how services can be provided. And, as I'm listening, I'm thinking to myself, this is something that, how do we foster that within our tribal communities? Because it's always been a challenge. One of our programs, our Painted Horse program, which is a diabetes prevention program, they're really good at facilitating, bringing other programs in to tribal communities. And so, but with that, one of the challenges that I've seen from the work that I've done, and just being a tribal member myself, is there's a level of trust that also needs to be fostered and developed when we have programs coming into our tribal communities. We have to deal with a lot of, there's a lot of misunderstanding about tribal traditions, tribal customs, tribal culture itself. But I also liked how Mike pointed out that when we talk about culture, it's not just ethnic-based culture. Our communities have so many different, we have a farming community, we have a cattle community, we have, it's varied on so many levels. And so it's important for me, from the work that I've seen and the work that I've done, to be able to bridge those gaps. How do we begin those conversations? How do we also work within our tribal communities to help build trust when we have a program that comes into the tribal communities? How do we get them to participate? How do we get our people to be able to feel comfortable with that participation? And so those partnerships are so important within our agencies and with outside agencies. So we do a lot of partnerships, of course, with USU and USU Extension. They've done amazing things within our tribal communities. But we also partner with Northeastern Counseling, Tri-County Health. And one of the key things I've really realized and have seen, because a lot of people will ask me, how do we get into tribal communities? The biggest and most effective way for anybody to get into a tribal community is to participate. Be there, not just on an assignment, not just because you have to be there, but to be there present in the community. When there is a community event, be present. That way people are able to start to see you and start to know who you are. And that right there builds on the whole concept of connection. Individuals are more likely to seek help if they feel connected to the people that are serving them. And so being able to see them at a community activity, it's like, okay, I recognize you. And then all of a sudden, here they are coming into our communities with a service. And so there's this level of connection. There's this level of trust that we're rebuilding. Regretfully enough, we experience in most diverse communities a form of judgment and misunderstanding. And so, one of the key things is to always remember, and I emphasize this a lot, is to remember that we don't need to fully understand what that culture is all about, but we just need to respect that this is the way they do things. This is the way a group of individuals navigate through their lives. This is the way they raise their children. This is the way they manage difficult situations. And so that level of respect is only, we can practice that by becoming more involved and more connected with the communities that we're wanting to serve. And so a lot of the work that I do is really bridging those gaps, encouraging people outside of our programs, because I've had an opportunity through my job to connect with a lot of different people. And there are amazing people with amazing services, amazing programs. But how do we make that connection? So that's basically it in a nutshell.
Great. Well, thank you very much, Michelle. Now we do have a opportunity here to go over some questions, and we had while those of you who are attending are thinking of your questions, preparing to type and write those questions in. I do have a question for each of our three panel members, and feel free to answer them in respect to your particular populations or area expertise that you work with. First question here, what do you think is the biggest barrier facing minority community members in rural areas in your particular group? What's the biggest barrier that they're facing?
So Mike, I can I want to answer that two different ways.
Sure.
If you think about it in just like a straightforward, fundamental way, I would just say housing and transportation. Like those are the two barriers that we're seeing that are just really difficult to answer. And I think understanding the barrier of transportation is really vital to people understanding, you know, like take, for example, if you wanted to get to all the places you needed to in a day and just use public transportation or walking or riding a bike, like I would challenge somebody to do that and include like going to the grocery store and getting your kid to piano, or if you had a sick kid that day and getting him to the doctor and trying to navigate that, even if there was even public transportation or bumming a ride or whatever you need to do. So I think in terms of barriers, that's what I would identify. And then there's sort of more this philosophical idea of what is this barrier? And I think Michelle did a really great job of just speaking to like understanding and adapting, particularly in healthcare, to the patient and making it like, when is it most convenient for someone to come into a, you know, to get a well child tech? Is it between 9 and 5, or is it really between like 7 and 9 in the morning and 4 and 6 in the evening? And are we making those times available? So are we thinking about how we really are making access truly available? Because it's more than just having a clinic in your community. It's also about having access to behavioral health and to physicians' hours that meet your schedule. So I think there's kind of two there. It's like this, the system that we've built and how it accommodates actually, is it patient-centered, and then just sort of the actual logistics, where do we see greatest need?
Great question. Thank you.
I will go and second the answer. For me, it's also transportation, but as a Hispanic, I will say the language barrier. And I know a lot of other community health workers, probably they don't work in the Alliance group at this moment, but they were inviting people to go to the clinics. And when they're over there, and if they don't have someone else who speaks the same language, it's a big barrier. How can communicate with the provider, how you can make them understand how you're feeling. Sometimes the people, they can say, okay, I have pain. What kind of pain are you? Can you describe that one? And it's so hard. If you don't have someone who can help you to interpret her at that moment, it's going to be a big barrier to give the right medication or the proper answer to those questions. I remember years ago, also as an immigrant, I was riding my bike because they don't want to sell me any car. I was having the money, but I didn't have a social security number. And then even I was pregnant, I was riding a bike because it was no transportation. I'm not talking because I didn't live here in St. George 23 years ago, but transportation is very, very important, especially here because we have several clients who lives in La Verkin, Hurricane, and they don't have the transportation. And if they have the logistic care thanks to the Medicaid, it's going to be a blessing for them. But what happened with some other patients who doesn't have that opportunity?
Great, thank you. Michelle, did you want to add on to that?
Yeah, so within our tribal communities, like we had kind of, like everybody had talked about, it's about transportation. You know, we can have, like in our area, we do have a local tribal transit, which will go to every community. We also have our local UBTA transportation, but even then that still has some barriers to it. You know, transportation, that's just so key when we're living in rural communities, and even walking to a specific location. You know, some people have to walk, if they choose to walk, are walking on some very busy highways, busy roads. And we do have a large oil industry here. So we've got a lot of semis, larger work trucks, a lot of things going on our roads. So transportation is a big thing. The other thing I feel is cost. You know, that whole cost that comes with healthcare. So we do, a lot of tribal members do take advantage of our Indian Health Service. And those who are employed with our tribe have their health insurance. But there's always those individuals that are in between those gaps, right? And we find that everywhere. It's like, it's almost like, in a sense, part of the term, but kind of preaching to the choir. It's like, everybody, it's like, get your screenings, find out where your levels are, look at, make sure you can meet with the dietitian. But it's those people that are that have fallen through, those individuals that don't meet those standard, requirements to get somewhere, to pay for something, that we really need to focus on. And so I think it's our at-risk population that is, a big challenge, making sure we're getting the right group of people, making sure we're getting the information, the transportation for the right group of people, but encouraging that. And so those mentalities are also part of those barriers, that barrier, that it's not just, and I know Amber talked about this, it's not just about those physical aspects like the transportation, the cost, but it's also mental barriers. When we go into a community, or when we come outside of our communities and go to another program, another, like a healthcare program, and then we start getting questioned about, well, how come? Sometimes a lot of community members, and I know this is everywhere, not just within tribal communities, don't really know how to answer that. How come you're not eating properly? Well, how do you really answer that? There's so many different, we have so many different components to that. And so I also feel that part of those barriers comes down to being solution focused, and that comes down to that mental component, or the way we process things. Sometimes we can go into a place and mull over everything that's wrong without coming out of that without any, with solutions. And so it's really all encompassing, not transportation, funding, but also the way we interact and the way we feel our comfort levels with the people that we're working with. So,
Great.
Yeah.
Thank you. Thank you. So we have two questions. We're going to address the first one and then go to the second one. This question right here says, thoughts on addressing the federal public charge rule when it comes to undocumented families, individuals, and helping address their health care needs. The public charge rule took effect in February of 2020, and it means that undocumented individuals who use federal benefits and programs like WIC, Medicaid, SNAP may not become eligible for residency or citizenship. Thoughts on that, on how it addresses the healthcare needs?
Amelia, do you have anything on that?
Yeah, some for the public charge, especially emergency Medicaid, is one of those things who are not at this moment, because the rules for immigration, they're always changing. Every time it's changing. But specifically that part on emergency Medicaid, it will not affect that situation for the public charge. That's why, for example, if someone wants to apply for Medicaid, they need to have the 5-year rule to apply for Medicaid. But that one is always changing. And especially for the pandemic in this situation is one of my questions yesterday, and they were ready to ask someone else. And on politics, we will not discuss that on this at this time right now, but they're working on it. They're working on that situation. But many families who doesn't have the legal documentation, that's why they have some other services. But for public charge, especially emergency Medicaid, it will not affect that situation.
Great. Thank you. All right, the next question here. This is also to Amelia. Working in a clinic that no one speaks Spanish, where can we go to find someone to translate for our patients if they don't have Medicaid or other insurance? And then the second part to that, what do you recommend as a good way to learn Spanish for those of us who would like to learn for our patients?
Okay, about the first question, every community health center who obtain some fundings from Medicaid, they can call a phone number and they can pair with someone who speaks the language, any language, you name it. I don't know, because I remember one day I was helping a patient in one of the clinics, and he speaks Farsi, and I was trying to, of course, I was using the phone and I was pairing with someone else who speaks that language because I don't know that language, of course. And if someone else, every clinic in Utah Department of Health is trying to put interpreters who are certified under the Bridging the Gap to work on those clinics.
Hey, Mikey, and I just add, you know, one of the policies we have at Intermountain is we obviously have translation services, but it's so important to have those trained interpreters and that we're not relying like on our 10-year-old child or grandkid to try and interpret these really important, you know, medical terms for individuals and helping them understand it. So I know sometimes we have to use what we have, but to Amelia's point, those trained professionals are like always the best way to go if we can.
Good. Thank you for that. And then the next question, I believe, Michelle, you were going to address that.
Yeah, so Quinn had asked, do you feel there is a barrier between elderly tribal members and following instruction of non-tribal doctors? That's a huge barrier. You know, a lot of our elders that have to have medical, you know, that go into the doctor, sometimes, you know, they don't fully understand the instruction that is given. And so I really like that question. You know, our elders within all of our tribal communities, we really, you know, those are the people that we really look to because they're the ones that hold our traditions. They're the ones that hold our teachings. But when it comes to medical, you know, going into a doctor, sometimes after you're in a doctor, some people will come out and they'll be like, well, what was he talking about? And so the person who went with them, with the elder, has to explain to their best of their ability what the doctor just told them. It's not necessarily in the language, but it may be just in English. How do you translate that? How do you get, like, you're supposed to take this every morning for one reason or for whatever reason, or like when we're dealing with Medicaid. So you guys talked about Medicaid. Now, isn't that the biggest rabbit hole in the world? And so within our tribal communities, you know, if our elders need to get on Medicaid, how do you get that filled out? How do you get that done effectively? And so, yeah, you know, our elders are so important to us, and most tribal communities will have a program that works with their elders, and so they'll assist them with that. But those barriers they're still there. You know, you do the best to transcend them and to help them, you know, encourage our elders to be healthy and to follow those instructions. But you have to be able, on the other hand, be able to explain that if they don't understand. Now, I'm not saying all of our tribal elders don't understand, but, you know, if there's that need to explain it a little bit more, that's always a challenge. So Quinn, I hope that answered your question.
Thank you. Great question. All right, so we've got a few more questions coming up. What do the health service providers need to know or change to serve the undocumented communities? And I know that would be a pretty broad question, you know, but maybe some small little tips that they can do.
It's so interesting, that question. For example, here in St. George, Utah, we have the community health centers, and one is family healthcare, and I'm really familiar with them because everyone I know, I invite them to go over there and try to talk with one of the providers. I know it's so different at this time with the telehealth and how to explain some other families how to use the telehealth or these kind of services to communicate with them. But the providers who are there, or the ones who we're working with, they're really aware of the cultural sensitiveness with the community they're serving. That is one of the things I feel really I have that privilege to see the kind of service they're providing to their communities. Of course, probably perhaps someone is coming from some other place and they don't have the experience working with this kind of communities, but at least they know we speak another language and we eat differently. And sometimes on the diabetes program, it's kind of hard to say the families, okay, you don't need to eat so many tortillas. And probably as a Hispanic, we will say, okay, don't eat so many flour tortillas, eat the corn tortillas, those can be better. But if they can understand that part of our culture, that helps a lot. And the good thing is it's a small community and they're working with a lot of Hispanics, MAs, in front desk who speak the language.
I would just echo what Amelia said, and some of the things that we've seen that have been really effective, like even with just screening for social determinants, if we have somebody at the front desk or an MA or anyone that, and this also even goes to the next question, what can we do to make minority groups feel more comfortable? But if there's someone there that they can relate to, that's very helpful. But the other piece of that is explaining what their benefits are. So one of the things and it's actually somebody from Family Healthcare, and she's been one of our champions in doing these health screenings, is that she lets individuals know, like, you're not taking advantage of the system if you decide you need the assistance of a community health worker. Like, this is included in your insurance. You're eligible for this. So making sure they recognize, like, you aren't trying to take advantage of the system. This is something that, you have as part of your insurance, or that your child has as part of their insurance. And so I think even just taking that opportunity to educate them that, you're not standing in line for handout. You have already qualified for this, and it's something that that we can assist you with. So making sure that individuals understand even just what they're, if they have insurance of any type or assistance of any type, or what they could qualify for. I think that's important too.
Great. Thank you very much, Amber. You've really touched on that question of what can we do to make minority groups more comfortable to access services. I know, for some of them that Amelia talked about, the idea of going to particular services or going to these places, there may be a stigma, or just culturally they choose not to. We are getting close to ending time here for our session. We do have one more question that we will have time to get to. If you do have another question, feel free to ask. If we are able to get to it, we will. So here's a question again, directed to Michelle. Michelle, one more question. Is there something that physicians can do better to better show the respect that elders deserve, and to better explain things that have been discussed?
So that's a really good question. I think the biggest thing is to just take the time. Sometimes when we go to a doctor, our doctors, our physicians, or the people that our healthcare providers, they're so stacked in what they have to get done. And so I think if a person understands that it's an elder that's coming in, and that it's going to take some extra time to explain, but then also to truly ask if there is any questions or what they don't understand. So I'm going to share an experience. So my dad, one time, he went to the eye doctor. This is kind of just what some of our tribal people have experienced. He'd gone to the eye doctor, and the eye doctor was telling him that he needed to do these eye drops. And my dad was just asking, why do I need to do these? And the doctor had a difficult time explaining to him why, and just told him that he needed to do it. And then he followed with another comment saying, you're a ward of the government. You need to listen to what we tell you to do. And so sometimes, I know I'm not saying this is a common occurrence, but sometimes with our older people, their physicians may get a level, people trying to explain things may have a level of frustration and not know how to explain. So taking that time to speak to them and just respect the fact that, our elders have their experience, and their experience is, a lot of them at the boarding school era, coming food, like our food distribution programs, being placed on, displacement. And sometimes people can come in with the idea, especially, I shouldn't say especially, sometimes people can come in with the concept that I'm here to save you. And so that you know, and so the way they interact with them may be a little bit different. And so I think it's just really taking the time to be able to sit down and listen to what the elders are really asking, and then take the time to be able to answer those questions with, you know, without feeling the rushness, without feeling rushed, without trying to get them in, get them out, because then that's where a lot of misunderstanding happens. So, yeah.
Great, great. Well, Michelle, thank you very much. Amelia, thank you very much. Amber, we really appreciate all the time and the effort that you've put into, and we appreciate the work that you're doing in these rural communities and helping these populations. As you can see here, we do have our contact information up here on the screen. We will be able to, and I believe we are going to be able to send out those PowerPoints, those slides for those attendees that would like them. Again, thank you very much. We appreciate your time and effort in joining the Rural Health Utah Association of Utah for this first online, fully online conference. There are still several other meetings later on this afternoon. So again, we appreciate you. And I believe that's all we have for today. Thank you so much.
Thanks, everyone. Have a great
This
Friday.
is Locke. Thank you very much. I really appreciate everyone coming on. And this is really important work that you've talked about.